Hi, my name is Anza from National Tainan First Senior High School, presenting a multi-polygenic framework for the differential diagnosis of major depression and bipolar disorder. Here is an overview of my report, and let us begin with the introduction. Major depressive disorder is the most common psychiatric disorder worldwide, with previous studies indicating a genetic factor of about 30 to 40%. On the other hand, bipolar disorder has a higher genetic component compared to depression. The characterization of symptoms include mood cycling between depressive and mania states. Currently, there is a diagnostic gap between the two diseases. If bipolar patients are correctly diagnosed, we can treat them with mood stabilizers and antipsychotics, leading to better outcome. However, due to some bipolar patients first presenting with depressive symptoms, many are misdiagnosed as major depression, and thus are treated with SNRI antidepressants, leading to increased mood cycling, mania, and generally leading to poor outcomes and lower quality of life. So, the objective of this study is to construct an accurate model for genetic risk stratification for the two diseases, and investigate relative insights through the model. Next, let's move on to the methodology. Here is a flowchart of my study, and let us begin with step 1. Here is my study size and demographics. We use a GWAS-based analysis. Through integrating the single nucleotide polymorphisms, we are able to calculate the polygenic risk score. However, this needs a correction due to our study conducting in an East Asian setting. In this equation, we can see a global term. This accounts for the shared disequilibriums with populations, while this term accounts for the local term. This accounts for the population-specific linkage disequilibriums, which is present in East Asian cohorts. By integrating the full equation, we can get the final polygenic risk score. We then integrate this calculation through multiple polygenic risk scores that reveal insights into morphology, disease behavior, and sociology. We integrate 112 of these factors, as well as 20 principal components that reveal insights into heredity and ancestral development. Next, let's move on to step 2. We train multiple machine learning models for differential diagnosis. Here, a white box lasso is used for dimension reduction. We then proceed to train random forest and support vector machine models. Here, we mainly discuss about random forest due to its higher accuracy. A random forest model is comprised of many decision trees. We can then calculate the Gini impurity, and via the smallest Gini impurity method, we can train a decision tree. Through random bootstrapping, we train multiple decision trees separately. And then, through majority voting, we can lower the computational cost and get the final result, preventing overfitting. For step 3, we obtain the insights. The receiver operating characteristic is a method to analyze the overall model accuracy by looking at the sensitivity and specificity at different thresholds. Integrating the area under the curve, we can get the AUC value. On the other hand, the Shapley analysis is used to find the contribution of each parameter. By accounting for these terms, we can integrate it into a Shapley summary plot. Next, let's move on to the results and analysis. Here is the lasso results, and we can integrate the top 20 coefficients into a selected model. We can note a higher accuracy compared to lasso regression due to random forest's ability to capture nonlinear interactions, while the clear Shapley summary plot also highlights the effectiveness of our PRS-CSS method. While we then train the entire dataset through the random forest all model. Some further insights include that we know the increased accuracy relies on deciphering ancestry due to the principal components becoming much more important at the full model compared to the selected model. We also note that the full RF model accounts for more dimensions without overfitting, which is intrinsic to the model architecture. We then analyze the ROC-AUC of the RF model. We can calculate the J statistic indicating a median separation. Well, through a pair t-test, we can note a significant separation compared to the null prediction hypothesis, while a moderate classification is done due to environmental influences. So here is the nodule. Our approach achieved a significant improvement from traditional literature models, with RF reaching the highest accuracy, highlighting its potential as a tool for screening. However, this also underscores the need for integrating environmental factors, as the genetic basis for both diseases are limited. Next, let's move on to the sociological insights. Here are the different factors for the two diseases. We can first summarize them into the psychotic neurodegenerative spectrum. We can note that schizophrenia and bipolar disorder have shared genetic architecture, which is possibly due to the presence of mania. Whereas bipolar disorder and Alzheimer's disease have shared mechanisms regarding degeneration, which we can see in the Spearman correlation matrix and the lasso and random forest models. We also find biomarker interactions, which can be separated into the immune axis and the neurofunctional axis. For the immune axis, we find an interleukin-7 immune pathway, which is the same as literature, while a new alpha-fetoprotein liver immune pathway emerges that is not present in European studies. We hypothesize this is due to the increased liver risks in Taiwanese cohorts presenting this new immune pathway. Both of them are linked to immune apoptosis and low T-cell activity. Whereas we highlight BDNF is linked to neural function, which influences growth, survival, and plasticity of neurons. By piecing them together, we can find the entire neuroinflammation picture of bipolar disorder. Some further insights include that alcohol and smoking are related to bipolar, whereas those sports are related to depression. This highlights that behavioral factors influence mental illness. For the conclusion, we constructed a patient data library, trained different models, and then, through the model insights, pieced together the hypothesis for the mechanisms. Here are my references, and thank you for listening.